The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Safe and Calm webinar for December 16th. This is Deanna Mitchell with Leading Age Michigan. With the holidays rapidly approaching, we fully know that everyone is extremely busy right now, but with vaccine distribution on the near horizon and a number of new guidance from CDC, we know that there's still a lot to talk about this week. Our agenda for today is routine. We will talk a bit about our webinar schedule for the next 2 weeks through the holidays. Dalton has a very brief advocacy update. Caseload numbers are improving, and we're going to cover that just briefly as well. And of course, we will talk about vaccines. There's so much information out there right now about vaccines. And at the same time, there are a lot of questions that are still up in the air, so it's kind of a challenge. We will review some of the more important elements in what we know to date this morning. Additionally, the CDC has updated its testing guidance for antigen testing, and we have a few other announcements as well. So we'll start with our holiday schedule. We will be holding our normal webinar this Friday, December 18, as long as there's content to cover, and usually there is. Next week, on Wednesday, we have 2 guest speakers for December 23. That would be Elisa Lintemuth from Dykema. She's going to be talking about the concept of mandating vaccines in our facilities and some of the pros and cons for that. And we also have Dana Prince from St. Anne's Home, who will be talking about their experience as a care and recovery center. And then we will hold a webinar on December 30 based on need only. So to get started, we will turn the presentation over to Dalton Herbal, who has a very brief update on what's going on in Lansing.
Good morning. As Deanna said, I have a very brief update. As you know, if you've been following this portion of the webinar, there are very few days left for which the legislature can operate. Specifically, there are 2 session days left, and right now we know that the Senate is not adding any extra days, and the House is kind of still up in the air from what I've heard as to whether they'll be adding a day or not, but that extra day would only be to pass bills related to extending the expiration of driver's license and things of that nature. So what does this mean to us? The legislature has also decided not to hold any of the lower ranking committees. So when you're thinking of the committee structure, a committee gets referred a bill from the full body, so the House or the Senate, and then the committees then report that bill after making changes back so that that chamber can take a vote on that bill. In the House right now, we have a ranking of committees. So for instance, Health and Human Services Committee reports to Ways and Means Committee, who then would report the bill to the House. All those lower level committees, so Health and Human Services, Natural Resources, a bunch of others, will not be held this week, and only the higher level committees will be held. So that's Oversight, Ways and Means, the Judiciary Committee. So this means any bills that were in those lower level committees are considered dead. They will have to be reintroduced next year. There's also a rule that each chamber must give the other chamber 5 days before they can take a bill that was sent from that chamber for a vote. So if the House takes a bill, passes it, and the Senate still needs to approve it, they have to wait 5 days. Since there's 2 days left, it means that any bills that need to cross chambers are also dead unless they kind of suspend the rules, which they're likely to do for some COVID measures, but not a lot of bills. So from our perspective, a lot of the bills we've been talking about were in Health and Human Services are dead. So that electronic monitoring bill will need to be reintroduced. That is considered not moving at this time. On another kind of topic, the COVID kind of relief bills that were kind of codifying some of those executive orders with flexibilities around volunteers and staffing, kind of formalizing that in the legislature or in Michigan law are also dead and are likely to be taken up at the start of the new year. So just to let you know, we're really winding down here, and we expect them to focus primarily on kind of large-scale COVID issues and some other things relating to the election. This is the important date slide. As I'm sure you know, the CRC and CRF applications were due yesterday, and then the next big deadline for us is the 31st. We continue to monitor, and I know National continues to monitor the situation that's going on in DC regarding COVID funding. Last I heard from National, the Senate and House have agreed to kind of split the federal relief package into two separate bills, one that covers state funding and liability protections for businesses, and the other that would fund or continue to fund PPP programs and other things like that. So they're kind of, the discourse is being separated in Washington. Additionally, I didn't have time to make a slide this morning because of a couple of technology challenges, and I'll cover it a bit more on Friday's call. We did have a call yesterday with the department to discuss some of the challenges and barriers to CRCs or to becoming a CRC. With a number of members were also on the call, and Aaron Emerson from MDHHS, and we were able to have a really, what I thought was a productive call, and they kind of recognized the challenges that we're facing, and we'll go into some more detail on Friday. I do have a small Q&A document about that call that I can distribute.
All right, thank you very much for all of that, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. As of right now, it actually does not look like we have any questions, so we can go ahead and move on.
Okay, thank you, Blake, and thank you, Dalton. On to the Michigan situation update. We have had some good news this week about caseload, and we'll look at those Michigan numbers. In particular, it does seem as if the Thanksgiving surge has been avoided in Michigan, so that's awfully good news. So we do have a significant amount of community transmission yet, but as you can see, the 7-day rolling average of Michigan new cases is rapidly declining. So hopefully that is a trend that will continue. The number of daily deaths, however, is remaining high. It does seem to have stabilized over the past several days, but of course that's not really a trend yet. We do anticipate that deaths should start to decline a few weeks after caseload declines. County positivity rates, and these are of course reported by CMS, they are just starting to improve slightly. A few red counties shifted down to yellow over the past week, although yellow categories that still indicates a significant amount of transmission. There's only a few counties in Michigan that have less than 5% positivity. The My Safe Start website is not, they're having problems with it, so it's not really operating well. And the last note that I have is that the state listed all counties in level E yet, but it's not really clear if it's been updated. So we will monitor to see if they've fixed the website shortly. New cases in skilled nursing facilities appear to be stable with slight declines as the data was reported on 12/14. You have to remember that there is almost a week lag time here in what's reported to the website, but that new cases do seem to be going down. HFAs also going down, good sign as well. You can see that they're down to 134 new cases over the past week as reported on Monday. Also, things are improving a bit in AFCs, but you have to note that for AFCs, there are still only about 80% currently reporting. In general, though, the number reporting each week has improved over the past month or so, so that's a good sign. And here are all the numbers for residents and staff across all three settings. The new daily caseload trending downward across all of them, as you can see toward the top. New resident deaths, though, increasing. And we think, hopefully, that that will start to go down soon. Staff cases across all settings, except for AFCs, increased as well. And again, maybe that is something that will start to trend downward when the community transmission rates start to trend a little bit more downward across the state. Those numbers hopefully will start to come down as well. So next we're going to start talking about vaccines, and we know that there are a lot of questions out there, and we have a lot of questions yet as well. And as I said earlier, there is so much information across many different agencies that it's a little overwhelming. So we have pulled from our sources all that we think is pertinent so we can tell you what we do know now. However, we, like everyone else, do not have a full understanding of how things are going to unfold, but we're monitoring it on an ongoing basis. This first slide is really just a list of resources that you might find helpful from Leading Age. They have produced an awful lot of documents and resource guidance. They also have a set of frequently asked questions that are updated daily. And we found these to be very helpful. So we're going to review that content with you shortly, but there's also a link to those FAQs on this page. In general, these are links from sources at the national level. We all know that the state is actually the one in charge of developing the protocols and the priorities for vaccines in each state. But these resources are certainly helpful. So starting with the CDC, they updated 2 sets of guidance about vaccines across the last week. We think some of this background information is important to understand, especially when you look at the resulting policies. And this guidance does answer some of the questions that our members have had over the last 2 or 3 weeks. When you look at the third bullet here, you can see that. It's important to note the CDC makes it very clear that during the clinical trials, the study only identified whether or not persons who were vaccinated became ill. They did not study whether or not the person was actually infectious. So we would think that if no one became ill, they would not have contracted the virus and was not infectious, but we also know that there are asymptomatic infectious people. So it's possible, although maybe not likely, that the vaccine stops the symptoms but not the infection. So the impact of that, the way they did these clinical studies, considering the time they had to do them in, it means that there's no anticipated changes in how you test, use PPE, or source control measures going forward. Any changes in that are likely to come from the rates of community transmission, et cetera. So all of those requirements that you're doing now, they're going to remain in place at least for a while. The other thing is that the vaccines will not impact testing results. If a person develops a positive test following a vaccination, you must treat that person as potentially positive. The vaccine will not be the reason for someone testing positive. If a person develops symptoms, you still need to pay close attention to that. And some of the challenges are that some of the side effects of this vaccine are the same effects caused by COVID. Fever, chills, headache, fatigue, etc. So if those symptoms arise within 3 days of the vaccination, you can consider those symptoms vaccine related. But respiratory symptoms are not related to the vaccine, and anyone who develops respiratory symptoms must be considered suspicious for COVID. Additionally, any residents with symptoms and prolonged exposure within the past 14 days, any kind of symptoms, if they've had prolonged exposure, they should be considered COVID positive regardless of their vaccination status. And they suggest that you could consider testing if the symptoms do not abate within 2 days. So you should treat them as under observation if they recently had a vaccination, but consider testing if the symptoms don't go away. And the same is true with staff. If staff have vaccine-only types of related symptoms and no exposures, they may continue to work as long as respiratory symptoms do not occur. And of course, if there is no improvement in their symptoms, they should be tested and restricted from work until you find out the results of the test. Any symptoms that are not likely to be vaccine related, even if they're paired with vaccine type symptoms, you have to treat those as suspected infections. So that was from the CDC. Here is a summary of the leading age FAQs, and these were updated as of this past Monday. There is some overlap in terms of content, but we will go ahead and repeat some of the things that we think are important. According to their conversations with HHS, the Pharmacy Partnership Program has been developed to cover SNFs, assisted living, and also, according to Leading Age, they've had conversations about this, HUD Section 202 communities. Although we have now heard from several sources, and this is a challenge we know, that independent living, including those persons in CCRCs, are not included, but the 202 communities are. We have also heard that if there are additional vaccine doses available during a clinic visit on a campus that has a multi-level situation in terms of, could have independent living on a campus, the pharmacy may provide those to those other priority levels as well. But independent living is not at this point intended to be in the first tier. And the next is a really sad but important point. We've been struggling with this for a couple of weeks. We have heard from the state and the feds that there is no defined way to confirm a facility's participation for most facilities until you hear from that pharmacy provider. Once we get some contacts going, we do know from Omnicare, and we have the ability to talk with them, but since we don't have a relationship with Walgreens, the state doesn't have a relationship with Walgreens, and the CDC and HHS has no inclination to try and figure out if someone is actually on the list for clinic site visits. It's been a real challenge to try and figure out who may be currently enrolled. So HHS has stated that they have enrolled over 70,000 organizations, and there is no one single database that has all the information. And we do know that some members signed up but have not heard anything. The state doesn't even know who has signed up in conversations with them. And they don't have any relevant contact with these pharmacies. And that was really a surprise to me, at least. So if you do not hear from the provider that you believe you signed up with in the next week or so, we suggest you call the local health department, and you may have to work to get vaccines from them. We're not sure. We do continue these conversations with the state about that. Staff will be covered in Michigan along with the residents. Data reporting will be done through the pharmacy. At the federal level, they have said that home health aides and hospice workers, unless they're coming to nursing homes or assisted living facilities, would not be covered. But Michigan, as you see later, does include home health workers, or at least certain home health workers, in that first tier. Plans for ongoing vaccinations are still not fully developed, so we don't have a whole lot to report on there. Physician orders are not needed. Fact sheets are going to be provided to the partners, and they're also on the FDA website. And we hear that the CDC is about to release a toolkit specifically for long-term care facilities, and there is a general provider toolkit already out on the CDC website. Again, excuse me, being vaccinated does not change any testing requirements for staff. And it is allowed, though, that our members can have an incentive program for staff to help them, encourage them to get vaccinated. And you can include temporary staff in your list of persons to be vaccinated. Members have voiced a lot of concern over the side effects, especially staff side effects. And excuse me, the feds have replied that that's the reason for 3 clinic visits for each facility. They want to, excuse me, minimize the number of staff.
Did you want me to move on to the next one, or are you still talking on this one, Deanna?
I'm sorry, I'm still talking on this one. I just realized I was muted.
No, you're fine.
So let me go back to staff concerns related to side effects. So the CDC suggests that beyond the 3 visits, which they're not going to do any more than 3 clinic visits, that providers who are concerned about staff illness could have perhaps half of their staff vaccinated through the program and have the rest vaccinated through the local health department if you're concerned about staff illness. The CDC understands that's not ideal, but they definitely don't believe that they can possibly schedule any more than 3 clinics across all these facilities. So members are going to have to think about that and make some decisions. There has been no clear guidance yet on whether to vaccinate recovered residents. You might want to confer with your pharmacy partner about that as more information comes out. We will be monitoring that, but we have not received any answers about whether or not that's appropriate. If a resident leaves your facility, they will have a card with a date range for the 2nd dose. And their options to get that 2nd dose, they will have the ability to follow up with your pharmacy partner, or they can go to the local health department, or if they go to another facility, the facility can help arrange for that 2nd dose. The CDC does not require consent, but they are advised. And we know that partners in general are using them. We do have some updates about that in Michigan in a moment. The link for all of these FAQs from Leading Age are at the bottom of the page. So the MDHHS webpage, the link is noted here at the top. The prioritization guidance for Michigan was updated over the weekend, but in reality, there is very little new here. This is mostly the same language that we saw over the last month or so. The first tier includes paid and unpaid persons serving in healthcare settings who have direct or indirect exposures to any patients. In other words, they have, exposures is the wrong word. They have direct or indirect contact. And that pretty much does mean your entire staff. Any office people, any people coming in and out of your facility on a routine basis, contract staff, temporary staff, volunteers, etc. It includes everyone. If they're unable to work from home, if you have someone working from home, then they would not be included. And then, of course, all of the residents will be vaccinated as well. The second tier includes workers in essential areas, followed by persons at high risk, and then, of course, the general public. So the department does have details about each of these subgroups, but we're only going to focus on the first, of course, which is most relevant for our members. The MDHH guidance provides a very broad definition of healthcare worker, and it includes the long list of everyone included here. And again, pretty much anyone who works in your building, including volunteers, contractors, etc., can be included. So in Michigan, they're starting with emergency medical providers, first responders, then they're going to move to hospital general units, emergency departments, and ICUs. They then will move to staff in long-term care and psych facilities, and certain home health workers who are serving persons at high risk or have a high volume of patients, such as ventilator patients, etc. Then residents in all settings, in all these settings, the long-term care settings. But we're not sure exactly why they differentiate that here, because in reality, they're going to be doing staff and residents at the same time. And then lastly, in this first group will be providers who conduct high-risk procedures, dentists, etc. Those are also in this first group. So the department also defines the health care settings included, and they also define what they consider an essential worker and those persons at high risk. We're not going to go into a lot of that. It's mostly, obviously the long-term care facility tier that we're most concerned about. I've included this slide. This is their statements about if there has to be some sort of rationing, if there are limited supplies of vaccine over time. They speak to how they're going to consider those priorities. However, this narrative was really quite vague, and hopefully over time we won't really have to consider limitations other than prioritizing where the vaccines go. We hope that they become more available very shortly. Do note that the department goal is that 70% of persons 16 and older should be vaccinated by the end of 2021, and that includes about 5.5 or so million persons in Michigan. This piece I thought was really interesting. The department on its website has a dashboard page that, I'm sorry, that's not the dashboard page. This is their plan for the distribution and for completing at least the first vaccination dose. They anticipate a 5 to 6 week time period for the first tier. And that's where the long-term care residents and staff are included. And we've heard from Omnicare that they're planning to start here in Michigan on December 28th. So it's possible that long-term care could be all immunized in the next month or so. Here is the dashboard page. So the department has put this on its website. And it's intended to track distribution and administration. By the end of the day on Monday, they reported almost 10,000 doses had been distributed across all of the sites in Michigan, and 10 doses, I don't think that's on this slide, but it's on another page that comes later. About 10 doses had been administered by the time they posted this on Monday. So I assume that this is going to be updated every day. Okay, questions about vaccinations?
Okay, thank you very much, Deanna. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos up on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. So I do have a list of questions here, so we will just hop right into those. Will insurance information be required for residents and staff, or is the government paying for all vaccines?
The government is paying for the vaccine. My understanding is that insurance information is required, though, because the pharmacy has the right to bill insurance for the actual administration of the vaccine. That's my understanding. I haven't heard anything otherwise recently.
Okay. CDC recommends 3 visits, but my Walgreens contact told me they are planning to vaccinate everyone on day 1.
Wow. Well, I don't know what your thinking is about this, but I would think that could potentially be problematic, especially if, you know, your staff have a lot of side effects. They are supposed to spread this out over 3 visits. I would think that you should talk to them, and if necessary, we can, we've had a hard time contacting and talking with Walgreens. So if you have a contact person for them, we would love to hear who that is. We've been kind of waiting for people to get information about who they're supposed to specifically talk to. But I would have some concerns about that, and I guess we should follow up.
Okay. We understand PRAC 202 are included, but what about MSHDA properties?
I don't believe that they are. The only thing that we have heard is that 202s are included. And I think that was only at the strong insistence by Leading Age at the federal level. I don't think that they were able to get any approval for any other kinds of facilities, although they tried.
One of the slides for your FAQ said home health aides and hospice providers are not covered under this program, but later you said they were. Any of our staff could get it.
Okay, so that was the difference between the federal and the state guidance. They did say that, and part of the issue will be whether or not they're coming into facilities. Any people coming into your facilities, a hospice worker coming into your facilities is going to be covered. Hospice workers in the community and home health workers in the community were not intended by the CDC and HHS, who are making the rules, to be included in this first group. However, the department in Michigan, the state, has included certain home health workers. Now, I don't know how they're going to determine that and how that distribution is going to be. And maybe that's something we can find out more about. But they wanted to include home health workers who were taking care of very high-risk persons, such as persons on vents in their home. We don't have any idea about how that's going to be distributed and managed, but we did note that they are on the Michigan list, but not the federal list.
Okay. We heard directly from CVS that we should include all team members, including administrative staff, corporate staff, etc. We also heard from other providers they understand it as any staff, not just care areas as well.
That's correct. So anyone who's going in and out of your buildings, including your corporate staff, can be included. That's our understanding.
Do we have any members who have been given a date from Omnicare?
I don't know. We heard from, my understanding is we heard from Omnicare directly that they plan to start on December 28th. I, at least, as part of the team, have not heard anything beyond that.
You mentioned that residents behind discharged will be given a card with a follow-up date. How about new associates and/or those associates that are leaving employment?
I would think the same thing is true. I believe that, well, first of all, they'll be given a card. There's a follow-up date. Everyone who's vaccinated will be given that card. Whether or not the pharmacy partner will be able to, and I don't imagine why they wouldn't, follow up that vaccination. But if they do not, there will be always access to vaccinations through the local health department.
My struggle is I have not heard from Walgreens and not sure which one will be administering ours. I am on the list from CDC. Has anyone else struggled with this?
I don't know. I heard from a couple members that they had not heard from Walgreens, and we have been working hard to talk to everybody and their brother about who to contact and how to deal with that. You know, we have a relationship with Omnicare, but Walgreens is a whole different ball game. Surprised to hear that the state has no contacts, and the feds really will not talk about confirming whether or not you're on the list or not. So it is our best recommendation that, one, if you don't hear in the next week, the best thing to do is contact your local health department and see what they can help with, if anything.
Okay. I think the 3 CVS visits are for first vaccine, second vaccine, and any add-ons that need first vaccine, and the third visit was to give the second dose to those new ones captured on the second visit. Thus, I think they are doing everyone's first dose on the first visit, not spreading our staff out.
That may be true. I don't know. However, the CDC's response to the leading age question about staff symptoms and concern about that implied that that was why that there were 3 visits. So I'm not sure how this is going to work out. Facilities who have concerns, I don't have a sense of how significant some of these side effects can be. I have personal experience from a flu shot. My arm gets sore for a couple of days. But some people do develop fevers and muscle aches and malaise, but we're not sure how intense or how often that's going to occur. If you're concerned about that, you can divide your staff out and have them vaccinated by the local health department. That's not a good answer. The CDC even identified that. So this might be one of those areas that's just kind of a challenge, and we're going to have to see how it goes moving forward.
Please clarify, I read that those who have recovered from COVID can get the vaccine from the CDC FAQ. I believe you said otherwise. Can you please restate?
Well, I was going from the leading age FAQ. So if there is CDC guidance, I would certainly think that that would prevail. We can check into that. The leading age FAQ from their discussions with the CDC said that they had not decided yet.
Okay. I received notification from Omnicare that our test could be as early as the week of December 21st, but have not received any specific dates. The person who called told us to work on having our consent forms and the multi-patient templates completed.
Right. Okay. We heard from them the 28th, starting the 28th.
Okay. Someone said they just heard from their contact at Walgreens yesterday. So that is something.
Okay.
And then someone said I received a call from my Walgreens representative on Monday, December 14th. So it sounds like they have been reaching out a little bit. I just forwarded an email that lists out the pharmacies that are taking care of which LTC facilities to your email. This could help that person's question. Okay, so I will look at that in a minute. Yes, the clinic dates are 21 days apart. Check the CVS document with the timeline. It says that the second visit is 20-some days from the first. We have to hope that issues of side effects don't take staff off work.
Right. Okay.
Pfizer and CDC webinar on Sunday also stated you could get the vaccine if you had COVID. You just need to be out of your isolation period recovered. AMDA has said the same.
Okay, great. Thank you.
How do you know what Walgreens is to provide ours?
How do we know which Walgreens facility is going to provide yours? I'm assuming that's the question.
That's
I have no way of I have no way of knowing that. Hopefully, as we get a list of some of these contact people, we can finally get a relationship with them and a conversation going. But we have not been able to date.
Okay, it looks like that was the last questions for now, so we can go ahead and move forward.
Okay. So even though there's all this vaccine stuff going on, the CDC did manage to put out a lot of updates in the past week or so as well. These three updates have very few new directives that have much content to them, but a bit more information around some of the topics. There's an updated infection control piece. It has a focus on environmental cleaning. And we have had a few questions about that recently, and so that guide is listed here in the link. An updated toolkit for shared or congregate housing is also out, and that has a lot of ideas about how to deal with, obviously, COVID in those facilities. And general updates for nursing homes. We did review that quickly. We didn't find any real new directives, but a lot more information. So those links are here for your review if you desire. So this was a little bit more challenging, and it has been challenging all along. The CDC did put out a bit more description about the plan for mitigating staff shortages. As you know, there is a conventional contingency and crisis level for these strategies. And we all know that one of the strategies that's been in their guidance for a long time is the possibility of using asymptomatic positive staff in COVID units where needed. However, at this point, even though a few members asked if they could do that a few weeks ago, we reached out to the state, they clearly said, no, you cannot use COVID positive persons, even in COVID units, if needed, to help with your staffing. This guidance continues to include that option. But it also talks now about perhaps not just allowing a asymptomatic positive person into a dedicated unit. They talk about perhaps just reducing the time of work restriction as a way to mitigate staffing challenges. And it suggests that if you decide to do that, you might want to look at, there's some considerations to look at. However, and one of the reasons why we included this is that it is out on the CDC website, but MDHHS, the department, has not approved any of this, just so that you're aware. So they have guidance, but I think that you're going to get a lot of pushback in Michigan if you try to do that. So here, we're going to talk about the CDC updated guidance on antigen testing. And to be honest, if it wasn't a little complicated earlier, it's a little bit more complicated now. They have created a new algorithm, but they haven't gotten rid of the old algorithm that talks about, excuse me, when confirmatory testing is needed. So that both of these, they're not in direct conflict, but one is a little bit more detailed and has like one recommendation that the other doesn't. So these changes are kind of I think they're very meaningful, though, when you take them all together. And the overriding issue is that this new algorithm allows for more clinical discretion, and really has been impacted by further information about antigen tests and their accuracy and the possibility for false results as that information has become available. So this is pretty much the introduction to the new algorithm. And the focus is on the fact, a very large focus, by the way, that the accuracy of antigen tests is highly dependent on the circumstances. And so when you look at how to interpret either a positive or negative test, you have to do so in the entire context that the test has been done. And of course, antigen tests are always going to perform best when the viral load is the greatest. So we're going to talk about this guidance in detail, and the link to this whole page and all of the new algorithm is there at the bottom of the slide. So in general, PCR tests are still considered the gold standard, but they are still only considered really meaningful when they're confirmatory and in congregate settings if they have a rapid turnaround time. If an antigen test is conducted before symptom onset or later in the course of infection, they'll often going to be negative because a person has to have a significant amount of viral load in order for an antigen test to detect it. So persons, we all know, can be positive in terms of infection, but the test might be negative because the viral load isn't greatest. The CDC will still state that false positives are relatively unlikely when the test is used appropriately, but false positives do occur, and that's something for everyone to remember. The likelihood of a false positive increases in areas of low transmission. And to be honest with you, I've never understood that. But that is something that has been consistent from the CDC over time. So if you're in an area of low transmission or you have a low probability of a positive test and you get a positive test, obviously you have to look very closely at that. And apparently, you know, this is true for all laboratory tests, not just antigen tests, that when you have a low probability of positive, the likelihood of having a false positive increases. And again, I've never understood that, but it's not very intuitive. So the CDC considers low prevalence to be an under 5% PCR test positivity rate over 14 days. And they identify that they're talking about PCR test positivity. Antigen tests are not included in that number. That's something that they want you to look at whenever you consider when you're interpreting the test. And clinicians must always consider that pre-test probability to appropriately interpret. One of the CDC concerns with false positives is that they can be affected by the integrity of the process. So they think that a lot of the false positives have to do with the actual procedure as it has been conducted. They remind everyone that test kits must be stored and handled properly. They can never be frozen. They always have to be at room temperature before use. And the kits must have remained sealed until just before use. They also have found that facilities who are processing large batches of tests may be having a hard time ensuring that the incubation time is accurate, and that is very important as to the accuracy of the test. And you have to, of course, ensure that you have enough specimen material to conduct the test. Another issue is that the time from sample collection to testing should be as short as possible, and the specimen temperature itself should be controlled. And obviously, if you have tested someone who's positive, but you haven't ensured that you have a very good infection controlled environment, cross-contamination could have occurred. And that, of course, will potentially impact a lot of test findings. So the CDC suggests that if you get multiple unexpected results, it's important to look at the process, to pause testing, look at your procedures, re-clean your surfaces, change your gloves, and run control specimens if needed. And they also remind everyone that in terms of the possibility of cross-contamination, that gloves have to be changed before collecting, handling, and processing each individual specimen. So here's the new algorithm and the link to it. The CDC has broken it down, so we're not going to talk about this in its entirety. We're going to talk about it by category: symptomatic, asymptomatic close contact, and asymptomatic no known exposure. So the first category is symptomatic. When dealing with a symptomatic person and doing antigen testing, clinicians can and should consider a positive test as a COVID-infected person, especially if you're in an area of high transmission. But if you have symptoms, you do a test is positive, you should consider it positive. If the test is negative, it should be confirmed with a PCR test. And of course, these persons should remain quarantined while awaiting test results since they're symptomatic. If a symptomatic person has had a recent contact, but both tests are negative, you should still quarantine this person for 14 days, even though there is no test confirming infection. But in a congregate environment, the CDC wants you to continue to quarantine anyone who has symptoms for 14 days. So that was kind of the easy part. Now looking at persons who do not have symptoms, but have had a close exposure, the CDC recommends following any positive antigen tests with a PCR test. And of course, because they've been exposed and they have a positive test, they should be isolated while waiting results from either test, really. If you're in a area where community transmission rates are high, right now that's pretty much the entire state of Michigan, except for a couple counties. If the close contact was over a long period of time, or if the close contact was from the same household, and if any of those situations apply, they suggest clinical judgment can be used to determine whether or not you really need a confirmatory PCR test, and that makes sense. In other words, if you have someone who doesn't have symptoms, has had a close exposure in terms of high community transmission rates, a continuous close contact, or from the same household, you can decide not to do a confirmatory PCR test, but consider that person positive if the antigen test was positive. Persons who have had close contacts and negative tests should still quarantine for 14 days. If a short turnaround PCR test is available for these kinds of exposures, they are suggesting that you might want to use a PCR test. If there are problems with safely quarantining, such as maybe in an AFC, where they're structurally maybe a bit more difficult in quarantining, or if follow-up testing might be hard. So the idea is that for someone with an exposure, you could go right to a PCR test if you think you need to. This last scenario is for asymptomatic persons with no known exposure. And this is the area where our serial routine staff testing comes to play. You can generally be sure that if there are no exposures or symptoms, a negative antigen test is to be considered accurate. But in areas of high transmission, judgment can be used to order a PCR confirmation test. But if you're doing serial testing, you wouldn't really do that. So the idea is that all point of care antigen tests are considered presumptive. But if you're doing serial testing, you don't have to follow up on your negatives unless there are symptoms or exposures. Any positive test, though, in this situation should be followed up with a PCR test. That's the real change in the algorithm. Before, if you had a positive antigen test and you were doing serial testing, you would consider that person positive. But you are supposed to follow this up with a PCR test. You do have to quarantine in the interim. And this is consistent with the recent guidance from the department, MDHHS, on antigen testing. So it feels a little bit better that the department and the CDC are closer aligned in their guidance about testing at this point. There's some important things to remember about confirmatory testing. You really need to do it right away. Even if you do it within 48 hours, you are still testing up to 2 days later, and the person could be in a different phase of viral load. If after 48 hours you cannot, and you test after 48 hours, you can't link those two tests at all. You're really testing two different, it's not a confirmatory test, in other words, at that point. If findings are different, you should consider the confirmatory PCR test in general accurate, even though potentially you might have tested in a later phase of the viral course. And a recently infected COVID person could easily have a negative antigen test, but a positive follow-up PCR test. That's not unusual. And if confirmatory testing is not available, which I don't think is true right now in our facilities, but the CDC states if it's not available, the clinician can decide on their own whether or not to isolate based on the antigen point of care test findings. So in general, the CDC states that antigen is still considered the appropriate mechanism for staff serial testing. And the reason for that is that it quickly identifies positives. And for serial testing, you don't have to bother to confirm all the negatives with PCR tests because you're going to be testing on an ongoing basis. Antigen tests, according to the CDC, are a good mechanism for outbreak control. But you need to test immediately for any symptoms. You need to test immediately the entire staff and residents if you have a new outbreak, and you have to do that frequently. You have to ensure you get your reports, and you have to apply interventions quickly. The CDC states that the whole process of outbreak response is only slightly improved if you're using a PCR test over a point of care test, antigen test. If you have fast reporting PCR tests, and they're not talking about 48-hour reporting, they're talking about fast, immediate PCR test reporting. There are a few products that can do that. They, of course, would be the best resource, but if they can't bring immediate results, point of care antigen testing, according to the CDC, has real benefits. So lastly, we're going to talk just a moment about COVID relief facilities. We met with, and Dalton referred to this later, but I don't think he understood I was going to speak to it. We met with MDHHS, some of our members as well. I think it was 2 days ago, but I'm not 100% sure. Time eludes me at this point. But it was this week. And the subject of conversation was the fact that a lot of members could not provide the dedicated staffing required to become a COVID relief facility. So through that conversation, which did go, we thought, very well, we thought the department was very helpful. They can support, they came back and said they could support a limited exception to allow nursing staff to work across two kinds of units, the COVID positive unit and perhaps the COVID observation area, as long as there was clear documentation of rigid infection control procedures and mitigation strategies. They also recommended that if this comes to pass, that IPRAC consultation to ensure that anyone with this kind of an exception would be providing the highest standards of infection control. So it's also possible, I don't know how likely considering that we only have a couple legislative days left, but there is some rumor out there that the legislature might be looking at some changes to that Senate Bill 1094 that defines the criteria for COVID relief facilities. Actually, that is the piece that absolutely requires the dedicated staffing for these units. The CDC recommends dedicated staffing for COVID units, but CMS and LARA are silent on that issue. There is no requirement from them technically that says you have to have dedicated staff in your COVID unit. But if your policies reflect that CDC guidance and you're not dedicating staff just to your COVID unit, you could be at risk for a citation. And Larry Horvath at the Bureau is looking to CMS for some additional guidance about that. Members who have not applied as a COVID relief facility are going to have to transfer persons as soon as practicable. We all know that the deadline was yesterday. We would recommend that members make sure to document each attempt to relocate residents. MDHS is aware that that there might be some challenges in that, and they're not going to be looking at compliance of that. As long as you're documenting, that's a good idea. But they will follow up on any complaints, but they're not going to be looking at this specifically to make sure that you've transferred your persons out tomorrow. So we're hopeful that we're going to get some exceptions here, and persons who think that they could perhaps become a COVID relief facility. At this point, we're not sure what the department will do about that. We do know that some of our members reapplied late yesterday, but hopefully this will allow some of our members to at least retain their current COVID positive persons. So, any final questions?
Yes, we do have a couple questions, so I will just hop right into those. Give me 1 second to pull those up. And okay. Can we review again on staff or residents positive with antigen testing and then within 48 hours get a negative PCR?
Well, it depends on, part of the dilemma is that it's not that simple. You have to look at the entire context. So you have to go through the algorithm, and if you want to go back, Blake, please, to the first, actually the second graph. That one, yes, no, that one. So it depends on whether or not the context. Is the person symptomatic? Have they had close contacts? Have they been exposed or not at all? Exposure and close contact, not exactly the same thing. So you've got to look at that. You've got to look at community-based transmission. You've got to go through the algorithm and look at each scenario, and then have your clinician determine if you have something that's unclear. you have to have your clinician determine using these decision tools whether or not to consider them positive, negative, or whatever.
Okay, what if you have positive residents in a memory unit and you do not have dedicated staff? Should you move the resident to a hub?
Well, if you don't have dedicated staff, I'm assuming this is a nursing home.
That I am not sure of. We can move on to the next one and come back to this one, and maybe they'll give us an answer on that. She said not a nursing home.
Well, that's hard. I mean, you could try to move them to a hub, and you certainly really are supposed to have dedicated staff according to the CDC guidance. However, the requirements for the dedicated staff, other than the CDC, are really only coming from the state, and only in terms of COVID relief facilities. So I think it's a gray area for anybody other than a nursing home. I would look at whether or not you feel that you can provide the appropriate safety precautions for a person who obviously has some possible dementia issues. And you also, if you were to transfer this person to a hub and make that work, you also have to make sure that the hub can handle those dementia issues as well. So I think that number one is a gray area, if I understand the question appropriately, and I would look to whether or not you think you can safely provide care for the person.
If cited, would it be a federal citation?
Is this the same scenario?
No, different question. I don't know. The whole question was just, if cited, would it be a federal citation?
So if you're talking about dedicated staff, if you got cited, it would be from the surveyor, considering, I'm assuming you're a nursing home, and it would be based on the fact that you are relying on CDC guidance. So if you don't have dedicated staff, you are kind of pushing the MDHHS guidance beyond the exception that was identified to allow people to cover observation and COVID positive units. But I think that any citations would be coming from your survey or licensing agencies because of that CDC requirement. I don't think that, let me reframe that. MDHHS is not going to come and knock on your door to make sure you have dedicated staff. That's our understanding.
Okay. Is it required that a specific clinician determine this? Medical director, nurse?
Determine, I assume we're talking about antigen testing? If that's the case,
yes.
It needs to be a practitioner. It can't be your charge nurse. It would have to be a practitioner. So it'd be a nurse practitioner or whoever the medical provider is.
Okay, thank you for that, Deanna. With that, it actually looks like that was our last question. So if you do think of anything after the webinar has concluded, as always, you can fire off an email to Dalton, Deanna, or safeandcalm@leadingagemi.org, and we will make sure to get that question answered as soon as possible for you. So at this time, we would like to thank both Dalton and Deanna. We would also like to thank the 100 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support support your staff, and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Our next Safe and Calm call will be as scheduled this upcoming Friday at 11 a.m. Eastern Standard Time. So we will see you all then. I hope everyone has a great remainder of their Wednesday, and we will see you shortly. Thank you.
Bye, everyone.
Take care.